Okay, tēnā koutou katoa. Welcome to this week's bioethics seminar series. I'm Josephine Johnson. I'm Associate Professor here in the Bioethics Centre, and I coordinate the seminars this year. Our seminars are every Monday when the university is in session, and we go from 1 till 2 p.m. So this is our second to last seminar for the semester one, and I'll let you know about what's coming up next week, and then when will we start at the end of this seminars. So the bioethics seminars feature speakers from all around the world, actually, but also close to home. And today we will be hearing from Charlotte Port, who's Emeritus Professor here at the University of Otago. Before we introduce Charlotte more formally and let her take the room, I just wanted to go over a couple of housekeeping things. So people on Zoom are coming on. People on Zoom are muted. So if you have a question and you're on Zoom, just feel free to put your question in the chat. Charlotte's going to give her talk, and as we always do, we'll let the speaker have the floor, and then we will have the question set in the question time. But if you feel like you already know your question, you can put it in the chat, and we'll come to it during the question time. I will keep an eye on the chat, and I will also take questions from the floor during the question time. So when we get to that part, if you have a question, you can signal to me, and I'll keep a queue of people in the room, and I'll keep an eye on the questions on the chat. Yes, okay. All right, so now I'm just going to introduce Charlotte. Charlotte is Emeritus Professor here at the University of Otago, as I said, and she worked for over 30 years in the Department of Preventive and Social Medicine. She is trained in medicine and epidemiology and has researched a lot of different topics, a lot of different conditions, including HIV, cancer, contraception, public health screening topics, and has a long-standing interest in the safety of medicine. And is talking to us today about puberty blockers. Charlotte doesn't have slides, so there's one slide that I'm going to put up, otherwise it'll be a blissfully PowerPoint-free series. Thank you, Charlotte.
Kia ora, Josie, thank you very much, and thank you for inviting me. I may say things that you disagree with, and I'm happy to be asked about them, but it would be great to do that at the end. I took my title, First Ask Questions, from an editorial in the Dutch Medical Journal. And the Netherlands is the home to the introduction of puberty blocking hormones for gender dysphoria, which is what I'm going to be talking about. And the editorial said, what is difficult for a good dialogue about this is that everything you say in the gender debate can be interpreted as an attack on supporters or opponents of early medical treatment. Shall we then replace first do no harm with first ask questions, primum rogare? So this is the idea, it's about asking questions that are incredibly difficult to ask, actually, at present. And I want to start by thinking about why talking is so difficult. It's an extraordinarily sensitive issue, and I'm aware of hostility to people who are trans. I'm aware that living as trans is difficult. I'm aware that public criticism of treatment practices can feel to some people like an expression of that hostility. These things give me pause. Still, I feel obliged to speak, and I think it's because there's two moral considerations which we need to hold together: respect for trans people and safeguarding the best interests of children. So openness is a principle of scientific practice and of medical practice. Medicine is a moral practice and depends for its legitimacy on providing evidence that can be examined on the balance of benefits and harms of any procedure. Of course, medicine falls short. It's not always open, and science is not always open, but I'm interested in that principle of openness, and again, that's one of the arguments for me talking. I have been reading and thinking and writing and talking about this since 2021. I was originally approached by younger colleagues seeing in their clinics young people who'd been treated for gender dysphoria while their mental health problems were unaddressed, and young people who regretted transition. They didn't feel that they could write or speak out about it. And because I'm retired, it's, you know, nobody's going to set me. Now, I want to say something about the politics of it. In the US, the approach to worry about puberty blockers has been political. 23 states have banned medical treatment for minors, that's less than 18. So that's not only puberty blockers, cross-sex hormones, and surgery. I don't think that that's the right way. My hunch is that the involvement of political parties in enacting laws to regulate medical practice is likely to fuel partisan animosity, greater discrimination against trans people on the one hand, and greater uncritical affirmation of hormones and surgery for trans-identified youths on the other. So what's the contrast to do it politically? It's what I'm calling the European approach, which has been through the health authorities, which has removed it from the political realm. So Sweden, Finland, Norway, Denmark, France, England are all taking this approach, doing reviews and then changing the medical practices. And some of them are part way on the way, but England, Sweden, and Finland have gone further. So one of the things I'm going to talk a bit about is the final report of the Cass review from England, which actually came out last month and was a 4-year review. And Hilary Cass was a very distinguished pediatrician. And the interesting thing about this, and sort of makes my point about not doing this politically, it's been accepted by both Conservatives and Labour. So it's not politically partisan. So we're going to have our only slide, please. Right. So what am I talking about? Now, this is data from an Official Information Act request. It's the number of people aged 12 to 17 prescribed puberty blocking hormones by year from 2006 to 2022. And Pharmac collects this data. It's a drug buying agency. It records medicines dispensed in its pharmaceutical collection. And these puberty blocking hormones are gonadotrophin releasing hormone agonists. And these are just all prescriptions, not with the indication prescribed. So we don't know what they're for, but they're just prescriptions or in fact dispensings. But I'm going to come back to that question. So these are puberty blockers. Gonadotrophin releasing hormones act on the pituitary to make luteinizing hormone and follicle stimulating hormone, which act on the testes to produce testosterone and on the ovaries to produce estrogen and progesterone. So actually, that's odd though, these are agonists, not antagonists, so that they flood the pituitary gland, and this persistent elevation suppresses the normal production of gonadotrophin releasing hormone. So the hormones that would set puberty in motion or continue puberty in motion, because they should be prescribed not before the first stage of puberty, which is called Tanner 2, suppressed. Since the 1980s, they have been used to suppress very early central precocious puberty. So that's before 8 in girls, so 7 or 6 or 5, and before 9 in boys. And then they continued till the median age at puberty, which in girls is about 10 and a half years. Puberty is like the very first Tanner 2, the beginning of puberty is very early. It's like, could be well before a girl gets a period. This is the approved indication for children. So it's actually approved for central precocious puberty, which is actually mainly in girls, about 5 to 1. And if we look at this figure, you can see that there's somewhere like 20 or 30 children that are on them in New Zealand. Now, actually, they should, I said they usually stop around 10 or 11 or 12. So actually, the use for puberty hormone for central precocious puberty will be higher than that, but there's still a few that will be on them into age 12. in New Zealand, we had the first guidelines for the use of puberty blocking hormones for gender dysphoria in 2011. And maybe they were used a little bit earlier than that because, you know, usually medicines can be used before they've actually got guidelines. And by 2022, we've got more than 400 children on puberty blocking hormones. And you can see that certainly if use for precocious puberty and sometimes for short stature is pretty small, the vast majority, if that stays stable, the vast majority of this increase in use is for gender dysphoria. Okay, where did the use for gender dysphoria come from? So it started in the Netherlands in the late 1990s for children, mainly boys, who are identified as the opposite gender. I just want to say a few things about these terms. So gender identity, an evolving idea that everyone has an inner sense of being male or female or non-binary, which might differ from their sex. And when these hormones are first used, these children would have had something called gender identity disorder, but actually that's changed in both DSM and the ICD codes to gender dysphoria or even just gender incongruence, which is part of a move to depathologize gender identity. So gender dysphoria is distress because of a mismatch between experienced gender and birth sex. So what was the rationale for suspending puberty originally in the 1990s? In fact, in the papers written at the time, there's a woman called Peggy Cohen-Kesenis, who was an adult physician, was concerned about the very high rates of psychiatric morbidity among adult transsexuals related to difficulties passing as the other sex. So it was surmised that if you prevented the bodily changes of puberty, it would be more easy to pass as the opposite sex as an adult. So so that was the idea. So a very small number were treated according to what became the Dutch protocol, had lifelong extreme dysphoria. So they had a diagnosis of dysphoria and had to be lifelong and extreme, were psychologically stable and had supportive families. The aim was primarily to improve final physical outcomes for those wanting to transition away from their birth sex and hence to improve mental well-being. Plus, they also talked about allowing an extended diagnostic phase, which became the sort of time to think idea, but an to see whether they really wanted to transition. And also to relieve present suffering, because, yeah. In 2011 and 2014, 2 papers were published on the outcomes for 55 of 70 children treated between 2000 and 2008. And I won't go into the outcomes, but they were certainly reported as positive. And from 2011, and especially from 2014, this medical practice spread around the world. And you can see here that our increase, maybe the increase starts in 2010, maybe in 2011. And then you can see a sort of leveling off before 2014, then an uptick, and then actually another change that I will come back to. Oh no, I'm supposed to talk about it now. Okay. So you can see from 2016, it goes up again. And then from 2018, and actually from 2018 to 2021, there's a very steep increase. So what happened during these years? So in 2018, we got the first New Zealand guidelines on gender affirming care, which actually came out from a specific group, but became the PATHA guidelines. That's the Professional Association for Transgender Health, Aotearoa. So this is not an approved indication. So the use for early puberty is approved use, but this is not approved, not by MedSafe, not by the FDA, not by the European Medicines Agency. And the other thing I want to note, oh yes, two other things I want to note about this, is only from 12 to 17. And some countries have had a rule that you can't prescribe puberty blocking hormones to children younger than 12, but that's not true in New Zealand, and actually now not true probably in the US. So when we looked at England and Wales, they had about 7 children under 12 that had been prescribed them in their latest update. But we don't know actually how many children in New Zealand have been prescribed them under 12. I do have some other data which I'm not going to show you about that, but this is an underestimate because it doesn't include children younger than 12. And the other thing I just want to mention is that when we look at, this is just numbers, but if we look at this as a rate, so the prevalence rate, I know there's some purists in epidemiology who want to call it a proportion, probably not a rate because it hasn't got time in it, but I'm going to call it a rate, is 110 per 100,000 aged 12 to 17. Compared with England in 2022, so that both 2022, just for gender dysphoria, 9 per 100,000. So that's more than 10 times higher in New Zealand than it is in England and Wales. So this is a huge increase. Use of puberty blocking hormones suggests both an increase in gender dysphoria and also an increase in prescribing for this condition, and both are relevant. So let's think about the increase in gender dysphoria or incongruence. Do we know if it's increased in New Zealand? And actually, one of the puzzles to me is that there's this Youth Health Survey 2019 knows all about, and they asked children at school in 2012 and 2019 about their identity, and 1% said that they were trans or non-binary in both. So it actually didn't increase in that school survey. But there's a very different report in the Growing Up in New Zealand study, which many of you will know, it's based in Auckland. And the children were 12 and 21, 22. So this is quite a young cohort. And they were asked about a non-binary or transgender identity. You know, mostly girl, mostly boy, always a girl, always a boy, in relation to their natal sex. And 8.2% of natal girls and 1.5% of natal boys, so very different, said that they were non-binary or transgender. So this suggests a very recent increase amongst children and young people, and mostly girls. But because of a lack of standard survey methods across countries, it's impossible to make reliable cross-country comparisons. So we know from studies in the UK, US, Australia, Scandinavia, that in other ways as well, we know that it's changed from boys to girls. So you can see this, this very high rate in girls in the most recent New Zealand data, from early onset to late onset. So in the original Dutch group, they all had lifelong gender dysphoria, and many of the young women have gender dysphoria that arises around puberty or gets worse over puberty. And I know there's some discussion about that, but that's the sort of simple way of putting it. They're more likely to have mental health problems and to be on the autism spectrum. So something like 20 or 30% on the autism spectrum compared with like a couple of percent in the general population. And in New Zealand, and I don't know about elsewhere, there seems to be a move to less advantaged children who are more likely to identify, like children in care have a higher prevalence of transgender identity than other children. Okay, so that's the first thing. Yeah, not very much increase, but maybe a really recent increase in gender dysphoria. What about an increase in prescribing? And I think there's two parts of this. There's, you know, it depends on whether it's accessible clinics, doesn't it? That whether children can go to those clinics, whatever happens, that they can go to those clinics. And so has that increased, and has there been a widening of the criteria for prescribing? And I don't have any actual figures about the increase in clinics, and I don't know very much about it. But we think that both those things have happened. We're pretty sure that the latter has happened. There's a widening of criteria for prescribing. And especially since 2018, which was the beginning of the gender affirming guidelines. And I mentioned that before, where there was actually approximate doubling over that period, 2018 to 2021. So both increases in gender dysphoria and increases in prescribing must be important, but neither would have much effect without the other. You know, if there are very few kids, even though there was plenty of facilities, there wouldn't be any. So, you know, both of them must have had a role. Right, next, I want to have a bit of water. I want to talk about the rationale for treatment with puberty blockers now. So I've talked a little about what the original rationale was. And again, I'm somewhat simplifying, but in order to, for clarity, I hope. So there's a shift in rationale from treating children with lifelong gender dysphoria to enable them to pass more easily as the opposite sex as adults, and thus to improve their mental health, to some other things. And for this, I'm using information from the PATHA 2018 Guidelines for Gender Affirming Care, some information sheets that were published last year, which actually were with the help of the Marsden Fund, and primary care guidelines in New Zealand from the age of 16, which doesn't apply exactly, but has, you can see similarities between these different guidelines and information sheets, and WPATH, which is the World Professional Association for Transgender Health, that released its SOC 8 in 2022, I think. Okay, so what is the shift in rationale? Instead of private concern with adult functioning and mental health, now the primary concern is with children's functioning and mental health. So these have been termed essential medical treatment to improve mental health, lower depression, suicidal ideation, improve quality of life. That's from the New Zealand information sheets by Johnson and Debris last year. Change from treating children with lifelong dysphoria, so expanding to include onset around puberty, and the current requirements in 2018 were persistent and well documented. Change from treating children who are psychologically stable to prioritizing medical treatment for gender dysphoria over mental health problems. Change away from using diagnostic criteria for gender dysphoria to self-diagnosis, self-determination, and informed consent approach. But still including, and perhaps emphasizing, this idea of time to decide, what was an extended diagnostic phase, into time to decide, or giving time, whether to physically transition as a rationale. Behind all this rationale is an assumption that this increase, or the increase in gender dysphoria or in trans identity, is due to social acceptability. That actually there is people are innately trans, and it's like same-sex. And I know that Nigel and I's work on same-sex attraction showed some increase over time in people saying they were same-sex attracted, which is probably related to social acceptability. And some people have even said it's like left-handedness, that I'm left-handed, but if I'd been a generation earlier, I would have suppressed it, or would have had it suppressed. So some ideas about innately trans and about social acceptability being the reason for the increase. Now I want to turn to the arguments of those medical authorities who advise caution. So the first thing is that we could turn this off actually.
Okay.
Thank you. The first thing is that we don't understand the phenomenal rise of gender dysphoria or incongruence. And I want to sort of quote Cass here. It's actually not plausible that an increase in social acceptability could happen this fast. And it cannot explain the shift from boys to girls, this move to more children with autism spectrum disorders and mental health problems, and a history of childhood trauma. Cass then discusses a number of plausible alternatives, including the effect of social media and social stresses, and what she calls manifestation of broader mental health challenges. For example, in the same way that distress can manifest through eating disorders or depression, it could also show itself through gender-related distress. And certainly some people who've detransitioned mention that that is what they thought was going on, that there was actually something else. The second reason for caution is that most children do not know their gender identity for sure. So there were early studies of gender dysphoric children, quite careful studies actually, and these are children who were gender dysphoric from an early age, felt that they were trans from an early age, that most desisted as they grew up, somewhere between 75% and 95% in the different studies. And actually interesting that WPATH, their number 7, actually cites these studies and cites them in some detail as a reason for caution. So another reason that children do not know their identity for sure. There's been a recent study of a cohort of young people in the Netherlands from 2001 to 2020, from ages 11 to 25, and actually 6 phases. So they asked them at all these phases, and it's 2,772 people. They measured what they called gender non-contentedness, which actually, I just looked up exactly what they said. I wish to be the opposite sex. Not true, somewhat sometimes, very true, often true. And what they found was that there were 3 different trajectories. There were 78% who said they'd never thought, wanted to be the opposite sex. 19% at some point said they did, and it decreased with age, and for 2% it increased with age. So these are ages 11 to 25. And actually only 0.1% did they exhibit this for all ages. So, for example, for natal females, 11% at age 11 were gender non-contented, and 3% at age 25. Of natal males, it was 8% and less than 2%. The third reason is the fact of regret in detransition. And it's incredibly contentious about what proportion desist or if they or detransition or regret it, and people can detransition without regretting it for sort of so it's a complicated issue, and I'm not trying to simplify it. The old studies show it's very rare, but even the one from the Netherlands, they had 30% lost to follow-up. So when they said it was only 1%, it was like, well, yes, but we don't really able to say it's 1%. Secondly, it's usually 5 or 10 years until people decide to detransition. So some of this, you can see, well, you can't see the graph anymore, but you can see it's very recent, this increase. And so we really don't know what's going to happen 5 or 10 years out. There's been an English survey, and there's other surveys that have a similar amount, that 20% have stopped cross-sex hormones within 5 years. So it's quite a proportion. Again, we don't know why. They could be still, might not regret transition, just don't want to continue to take hormones. What are the reasons for people to detransition? Again, Cass has got a list going from the most common to the least common. I'm just going to read it out. Check my timing. Health concerns, transition did not help with my dysphoria, found alternatives to deal with my dysphoria, unhappy with the social changes, change in political views, dysphoria resolved itself over time, comorbid mental health issues related to dysphoria resolved, or solved, actually, unhappy with the physical changes, lack of support from social surroundings and financial concerns. So interestingly, lack of support from social surroundings was actually quite low on the list. Right. Okay. So if most children do not know their identity for sure, and it may not persist, we should be very careful about putting children on a medical pathway, if we're putting them on a medical pathway. So then that's the next question. Puberty blockers actually do not allow time to think or time to decide. The studies that have followed children and young people given blockers over time have found that more than 90% go on to take cross-sex hormones. In the systematic review, it's 92 to 100%. So in practice, it doesn't buy time to think. Now, it could be because of very careful diagnosis and assessment only prescribe puberty suppression to those who are really transgender. And maybe some of these, that's a possibility for some of the studies when they put on, if they'd had lifelong gender dysphoria. But Cass suggests that puberty suppression itself might alter the trajectory of development of sexuality and gender identity and prevent neurocognitive development. That is, put children on a medical pathway so that puberty blockers are actually doing that. Whatever reason, they don't give time to decide. Puberty blockers are not known to be effective or safe. So there's been systematic reviews from Sweden, NICE, the National Institute of Clinical Excellence, in 2020. It was updated 2024. York University, Taylor et al. I've actually read quite a lot of these, all reach the same conclusion. There's not enough evidence to recommend routine use. And I can discuss the limitations of the current studies at the end if people want to discuss that. So Cass discusses effectiveness in relation to the potential aims. First of all, does it buy time to think? It doesn't do that. Secondly, I'm just saying what she reported. Does it reduce gender dysphoria? No, it doesn't. 3, does it improve psychological and mental functioning? Inconsistent results. Cass suggests she would have expected to see bigger effects, even if there was no true effect, because this is seen when there's a strong belief in the efficacy of treatment, what we call a placebo effect, which usually disappears in randomized trials. So the effects, when they were found, were pretty small. Cosmetic outcomes in adulthood, yes, especially for trans women. So trans male to female. Voice, facial hair. Oddly, and I don't understand this actually, Cass says it's not relevant for trans men, female to male, because testosterone will do all the masculizing, although presumably there's an issue about breasts. Cass also discusses the potential harms, altering the trajectory of development of sexuality and gender identity. And I'm sure you're aware that many of those who desist say that they were gay or lesbian, and that was sort of what they found out through going through this. Temporary or permanent disruption of brain development, impact on subsequent genital surgery, which I can discuss if need be, that bone growth is compromised and it's unknown if it recovers. So Cass concluded that we shouldn't use puberty suppression except in research setting. And she suggested that it will be those with early onset gender dysphoria, and I presume probably mostly males. But that means, and this is incredibly important, we need to find other ways to deal with young people with gender-related distress. This is a huge issue. We all will know young people with gender-related distress. We need to treat their mental health problems, and we need to examine other psychological approaches to gender dysphoria, which has also not been studied. You know, it's quite right. People say, well, you say the hormones we don't know if they work. We don't know if the psychological approaches work either. We don't. But if we think that we shouldn't be using hormones, we need to examine psychological approaches and find things that do work. Cass has a whole little bit on why do many young people and parents see things differently, and I can come back to that. Okay, now I'm going to turn to the last few minutes. It's all right, I've got 7 minutes or something. Turn now to the situation in New Zealand and the implications for the medical profession and for the medical profession's moral standards. We have very high use of puberty blocking hormones in New Zealand, perhaps the highest in the world. With some colleagues, we've done some other comparisons among countries, and so far we look to be much the highest, but actually the data from other countries is pretty terrible. So I won't say it's definitely true. Importantly, the health professional group PATHA, Professional Association of Transgender Health, Aotearoa, has rejected the CAS review as irrelevant and advocated for the continuing use of puberty blockers as life-saving. How then do we persuade the medical profession in New Zealand to take CAS's conclusions seriously here? And also, of course, more openly, how do we have a dialogue between those who reject the CAS review and those who support it? So how do we persuade the medical profession to take the CAS conclusion seriously? So my challenges to the Medical Council, I want to set out how the current practice of using puberty blockers for gender dysphoria and incongruence breaches the Medical Council standards for good medical practice. The medical profession is not a law unto itself. It's given its self-regulatory powers on the basis that it serves society and sets its own standards that are open to public scrutiny. And actually, I wrote a statement of concern to the Medical Council about a year ago, setting these things out, but I didn't have any luck. Okay, first, these hormones are not licensed for gender dysphoria, reflecting a lack of evidence about benefits and harms. The Medical Council standards stipulate special responsibilities for such off-label prescribing, which appear to be neglected. As innovative treatments, they should be carefully monitored, but this is not happening. And the answer to that is to use in a research setting only, or to make sure that data is collected and that everybody's followed up. Second, the Medical Council standards stipulate that a diagnostic assessment should be made before prescribing treatment. So you should only prescribe medicines when you've adequately assessed the patient's condition. However, current practice, and I'm relying particularly on the information sheets released from Auckland last year, suggests that treatment is based on self-determined gender and no diagnosis of gender dysphoria and no psychological exploration of other possible reasons for gender distress. Third, the Medical Council standard stipulates that you must prescribe in the patient's best interests, not simply because the patient demands them. So best interests is a special case for children. You know, we're competent adults, we can assume to understand our best interests. The doctor has to consider not only what the child and the parents want now, or even seem to need now, but what is the child's best interest, considering the future autonomy interests of the child. So that's really both for the child and for the parent, that they have to protect the future autonomy interests of the child. So the idea of a child's right to an open future picks up on this matter. There's a guy called Joel Feinberg, who's a philosopher of education in the 1980s, wrote about the child's right to an open future. And he talks about rights in trust, which look like adult autonomy rights, except that the child cannot very well exercise their free choice until later, when they're more fully informed and capable. And the best interest might be violated if this right to an open future is violated. Fourth and related is the capacity of children and young people to consent to these treatments. So the Medical Council principle of informed consent starts from the position that every patient can make their own decisions unless there are reasonable grounds to believe otherwise. When the patient lacks capacity, you should contact someone who has a legal right to make decisions on the patient's behalf. So it's clear that a child or 9 or 10 or 12 does not have decision-making power to consent to puberty blockers, especially in the circumstances that this will almost inevitably lead on to cross-sex hormones. And if Cass worries about irreversibility of puberty blockers, of course, the case is much stronger for cross-sex hormones. So for a young woman on testosterone, it will have effects of bodily changes, potentially on fertility, and potentially affect sexual function. Given what we know empirically, this blocks the child's right to an open future. Even if this is a repeat really, even if the parent who holds these autonomy rights to child should not agree, even the parent should not agree to this treatment in the interest of the child's right to an open future. 5, clinicians must provide accurate and balanced information that is sufficient information for patients to give informed consent. And actually, I won't go into the details, but there's these recent information sheets, which are widely used now, do not give an accurate and balanced picture of the risks and benefits of puberty blockers to enable informed consent. So my conclusion, that the Ministry of Health, we're all still waiting for a statement from the Ministry of Health, I think. The Ministry of Health has done its own, they call an evidence brief, which I think is a sort of systematic review. And I don't know how it will differ. But, you know, in fact, I've said I don't see why they're doing their own. I don't, you know, there's a lot being done overseas. I don't think we've got tremendous expertise in New Zealand to do it better. But they're also going to issue a statement, and that's not come. I think they must review the use of puberty blocking hormones. I would hope that they would become used in a research setting only. And medical counsel, it's important for them. They say where standards have been breached, we will take action to investigate breaches. So this is my attempt to get them interested. And lastly, on a slightly more philosophical point, though I've noticed the importance of some principles and values, I believe their interpretation depends on empirical evidence. So even the child's right to an open future depends on empirical evidence. If we knew we could identify a group of children who would definitely stay trans-identified into adulthood and for whom not suppressing puberty would lead to long-standing mental health problems because of difficulty with passing as the opposite sex, then arguably we will foreclose the child's right to an open future by not suppressing puberty. But we can't identify these children. Even under the original Dutch model, there were regretters and detransitioners.
Okay, so we will have questions from the chat and also questions from the room. So I'm just going to take 1 second here to just note whoever's already got their hands up. I was going to not give a priority to my other. So I'm going to deprioritize my colleagues, but I will put you on the list. And then I will start here. I'm sorry, I don't know your name, but sure. Yeah. I'll hear, and then I'll go to Nigel, and then I'll do the chat, and then I'll come back to my 2 colleagues.
I just would be interested to know what the parental child, you sort of briefly mentioned that there was some kind of difference, because one of the possible explanations for the rise is pressure from parents, for whom I have a lot of sympathy. You said something about that there was the difference between the child and the parent's view or something.
I'm not sure I did.
Okay.
So when I said about the rise, that was all young people themselves and where they would get and the different reasons that they might be they might have developed dysphoria, gender dysphoria.
Well, I'm talking about the prescriptions.
Oh, the prescriptions. So I think that there has been a change that originally the family had to be supportive for children to be in the original Dutch protocol. The parents had to be supportive. The 2018 PAPA guidelines say, well, if the parents aren't supportive, then they find someone else who will be supportive. So that does suggest and anecdotally, there are very unhappy parents whose child's been put on puberty blockers.
Nigel?
Thank you. Thank you, Charlotte. Very interesting. But if there was going to be, as you say, sort of maybe prescribed into a research situation, then I think one would think about who are the clinicians that are doing this. And I imagine they're predominantly pediatric endocrinologists, or is there a specialist group who do the prescribing? In which case, could they be engaged?
Yeah, no, I think that's a really important thing. So I think there's pediatricians and there's pediatric endocrinologists. And there's also psychologists who are involved. I think the child psychiatrists are now less involved than they were. But yes, absolutely, it ought to be, that ought to be the aim, to have a lot of discussions that would assist in finding a resolution between these two groups.
Has you've been discussing those groups, as you know, or did you just not aware? Are they actively considering it, really?
So I'm in touch with one pediatric endocrinologist in Auckland who is like, it seems as if there's some who are very pro and there's some who are pretty very cautious.
How many are you talking about in New Zealand? I didn't know we had that many pediatric endocrinologists.
I'm sorry, I don't know.
I'm going to turn to the chat. So there's a couple of things in the chat that are here for information, I think, information purposes. But Kelly White has asked a couple of questions as well, and I'll get to the last question in a bit. But one of the question is, you advocated both empirical evidence and using psychological treatments for dysphoria in childhood. What psychological treatments have been validated for dysphoria in this age group? Have these been validated to a higher standard than puberty blockers? And Kelly also asked about, I'm not quite sure, as individual treatments, these should be closely monitored, but this is not happening. Source, I'm unaware of New Zealand research on this. So yeah, does that make, how's that?
Yeah, I just write them down.
I'll come to the room and then I'll go back to the chat.
Okay. Well, actually, I did answer that question. So Cass has recommended psychological treatments, but she said, actually, we don't know. We know that we must and do know how to focus on the mental health problems that these kids have, and we mustn't any longer ignore those. So depressed, whatever it is, we do know about those, but what we don't know, and she suggests we need to find out about good psychological approaches. And I know some people say that it's the same to, if we don't know about psychological treatments and the long-term effects of psychological treatments, and we don't know about the long-term effects of puberty blocking hormones, why not just say, well, they both can go ahead? And I guess it is about a question of harm. I guess that's the, it's about this irreversible effects that, and the unknown irreversible effects that we have special responsibilities with medicines, which is how the system's set up.
So John, then Mike, then this person here.
Oh, I didn't answer I said unaware.
This is a question here. As individual treatments, these should be closely monitored, but this is not happening. It's the quote from you, I think.
Yes.
Source, I'm unaware of New Zealand research on this.
Yes, I'm unaware of New Zealand research on this. Yep.
John, then Mike.
Hi, Charlotte. Congratulations. Well done in talking about what's perhaps the most contentious issue, perhaps the second most contentious issue after Gaza. So a couple of quick remarks. So the first was the open future considerations might track in the other way too. So they might apply if you don't provide.
Yeah, and I said that. Yeah. I said that, and that would only apply. So I was saying yes, but these principles really they depend on the empirical evidence.
But I think I'm not sure that wouldn't be my choice of thinking about future interests of children to unpack it, because someone can easily argue the other way. But the second point I wanted to make was I haven't read the Cass report, and I probably should.
Yeah, 300 pages.
And I didn't. I didn't realise that it made a claim about how puberty blockers didn't buy time. And I want to read it because it sounds counterintuitive to me, because of course people pay puberty blockers for time. And so there must be a sense which is buying people time. But it seems like the problem is that because people go on to have therapy afterwards, it hasn't bought them time. And it reminded me of the Tavistock versus Bell decision in the High Court, And what they said the same thing. They said that puberty blockers can't be disentangled from the later treatment decisions because people progress.
Yeah.
And they also said that they introduced age bands at which people couldn't consent to puberty blockers.
Yeah.
That judgment was overturned in the Court of Appeal, and the Court of Appeal affirmed that it was up to clinicians to determine whether or not a child had sufficient maturity and understanding to make a judgment about that. So it's a suggestion to have a look at the Court of Appeal.
So, no, I've looked at all
Yep.
the stuff. So the Court of Appeal, actually, it was a point of law that it was not up to that High Court to say that they should go to court, that doctors had to go to court. That was almost a technicality. But so unpicking this thing about buying time. So the argument went, and it was maybe best expressed as a prolonged diagnostic period in the early reports, that maybe only 10% would actually want to really transition, and that 80% would come off puberty blocking hormones, and puberty would recommence. So if they were on them for a year, 2 years, whatever. But actually that turned out not to happen. That actually in the Dutch study, 98% of them went on to puberty blocking hormone. So I think our difference here is just simply one of interpretation, what time to think means. So time to think, that extended diagnostic phase meant meant that a significant proportion would not continue on.
Can I go, Mike, and then to this person in the back here, and then I do want to get to what's online, so we'll just keep going.
Sure. Okay. So I'm just great talk. Thanks, Charlotte. The polarization that you picked out in the state, obviously a big issue, but also seems to be reflected in medical practice as well.
Yeah.
I'm just wondering if you had any thoughts, because it seems very unhelpful, and it's unhelpful for making progress on the issue. I'm wondering, so you recommend that, sort of more or less, you agree with the CAST report that any use of puberty blockers should be as part of an ongoing clinical study.
Yep.
I wondered if that, do you think that could be a depolarizing approach? Is there a way that a clinical study could produce evidence that is accepted across these polarities? And if you had any thoughts about that, because that seems sort of ambitious to me, I think. Look, but that's what I'd like it to do. I think everyone with an empirical background would hope that does the work.
Well, of course, it's going to be up to the Ministry of Health to make that call about whether to, recommend a research setting for use. And I mean, I think the research setting, the primary reason, there's a reason for the kids themselves that they'll be very carefully monitored, and they, they'll make sure they have psychotherapy as well as having puberty blockers, whatever. So it would be absolutely best practice. We'd have to define best practice. But so as always in trials, actually, the people in the trials get better treatment, people outside trials. So that's a very good thing. But then it will give us that long-term information. So there are people who believe that most of these children are going to be better off as in their trans identity. So it will be able to show that, and it might also be able to show whether you can decide at an early age what is the subgroup that will go on. So I do think that's, you're helping me to make the argument for that being a good way forward. Yeah.
Okay.
That's what I'm going to ask. If any of these particular groups they invoke the Hippocratic Oath?
I think the Hippocratic Oath says first do no harm, but it's got the same old problem that what's harm? Do you know what I mean? That these principled things actually come down to empirical things. And in relation to my work on Dr. Green's study at National Women's, the people who think Green was a hero said he first did no harm because he didn't treat the women. I mean, of course, they had pre-cancer, so they should have been treated. So people can use these big principles, but actually you need to look underneath it.
Okay, we've got a few more questions online. I'm trying to figure out how to get to them. So one of them is about off-label use of medications, pointing out that off-label use of medications is fairly common.
Yeah, I'd like to talk about that.
Yeah, okay. So, and they use the example here of major depressive disorder, which is off-label for children. and teenagers. Do you believe that the same standard you're advocating for puberty blockers should be applied to antidepressants and under 18s? Prohibit their use entirely and insist on alternative treatments? If not, why is the off-label use of these medications different?
Okay, so yes, it is different. So, and again, both Cass and I think this, that you commonly for children, there's off-label prescribing when the adult medicine is used for children, but it's used for the same indication. But actually, this is a different indication, so it's a different situation. Of course, we should be very careful about using antidepressants, especially SSRIs, under the age of 18, because we know there can be very severe adverse effects. So I'm not saying we shouldn't be cautious.
Okay, and then we've got a few questions here from Jack Ruth. So I'll just going to one of them is about the Cass review as a major source, yet there are many questions about the validity of the review. Why are you privileging the Cass review?
Yep.
And have you talked? Are your opinions in line with what PATHA is saying? So I think situating your opinions there, and there's a question about, are you in contact with trans advocates or experts in our community? So that's a group of 3 questions.
So you might have to come back to them.
Yeah,
but so first of all, about Cass. So I'm talking mostly about Cass because she's done the biggest report and the most explanatory report. But actually, in terms of the last thing, which is the most sort of, I think, contentious at present for those who are rejecting the Cass report, is this weighing up of benefits and harms. And I've been writing about weighing up benefits and harms for a couple of years now, and have drawn on individual studies and also on the other systematic reviews. So NICE did a systematic review in 2020. The Swedes did a systematic review in 2022. I've got all these here, actually. It's really worth looking at them. And it's really interesting they give a very careful discussion of why they haven't included some reports, why they've only included 50. I mean, there's been a sort of a silly idea that Cass only looked at 2 reports, but actually, I mean, it was not done by Cass, it was done by the University of York team, but they rejected, they had 50 that they thought were of moderate quality, but then they only looked at 25, moderate and poor, whatever. But it's very simple, the reason they reject them. If you start with 100 people and you take all your measures on them, and you end up with 50 people and you take all your measures on them, then actually they can be a different group of people from the 100. So you can't just, there's nothing esoteric about the reasons that certain studies have been thought to be uninformative. Actually, they're very ordinary, and they're my bread and butter, that stuff.
I know we've just got 3 more minutes, so we're really up against time, and we will leave questions out, I'm sure, that we won't be able to answer. But can we just go to one here that's got a couple of
somebody with their hand up.
Yeah. Thumbs up. Oh, okay. It's actually Jemima Bullock, whose question I was going to go to. I don't really want to have a different set of rules for any online person, so online attendee. I'm going to read Jemima's question. Yeah. My biggest concern here is that you're advocating to withhold effective treatments to support trans children that have been thoroughly assessed in New Zealand. I think that's the children, usually by a psychologist and a medical specialist, and will have the full support of at least one parent. Retrospective data indicates that most adult trans people were aware of their gender as a child. Do you believe trans children exist and or should have a right to medical treatment with the appropriate assessments as already done in New Zealand?
So I guess that my whole talk tried to answer that question. I tried to answer the question about whether we knew that children were truly trans. I mean, some children are going to persist in a trans identity into adulthood, but we don't know, we can't identify them. We can't certainly identify them. The question about whether the treatments are effective, I think I've gone into that in some detail about the benefits and the harms, and actually the lack of knowledge. And so I've been trying to think hard about this, that when you work in a certain area, you see people doing well and you think, well, I can tell, that's my job. I can tell they're doing well. How dare you come along and say they're not doing well? Well, it's true. And I would say, well, have you published anything? Have you got all those children at the beginning, followed them through, and all of them at the end? And medicine is just so littered with examples of where we've been very positive about treatments, just from, I don't say just because I think that clinicians have the most important role in helping and assessing their patients. But we can just get it wrong and we can do a lot of harm. And so we have to, I did work on no, I won't go to that. I've got to.
Okay.
But the whole history of medicine is littered with situations where we thought we were doing good, and I believe the people who are working with these children believe very much that they're doing good. But I'm asking them to stand back. And actually, if you look at the Cass review, Cass discusses a whole lot of reasons why parents and children might feel that what she's saying is not what they think.
So I want to thank you, Charlotte. I'm really sorry for everyone who has more questions, people who are in the room are lucky enough to be able to maybe ask them after we finish, and people online. We just have too many questions online to finish all of them. So, but people can get in touch with you by email. So thank you very much.